I guess, you guys are all here to have more awareness about eating disorders. We'll start with eating disorders in children and young people. It's an interesting topic. You guys see it in your day-to-day practice, not every day, but at least sometimes, I guess. I want to make this talk as practicable as possible. I want this to be useful in your day-to-day practice. So imagine you have I think it might have happened in your practice, but let's for the discussion's sake, imagine you have a 15-year-old young person named Annie brought to you by a parent and complaining about losing weight and not eating. I just want you to think for a minute, what are the differential diagnoses you would be thinking? You are welcome to write in the chat or say it.
We've got some people adding in depression, diabetes, hypothyroidism. Yeah, depression, anorexia.
Yeah.
Got lots of responses coming through. Could be a number of things. Yeah, GI complaints, a number of different GI diseases.
Yeah, good.
Drug and alcohol misuse.
Yeah.
Celiac.
Yeah. Okay, shall I move on? Yeah, good enough. Okay, that's good. Yeah, I think you pretty much covered everything. Yeah, mostly everyone would think of eating disorder, which is common, but it's just remembering there are other causes as well that could present as eating issues, like malignancy, any chronic infections, gastric causes, like you mentioned, celiac, Crohn's, any endocrine causes. Again, you mentioned diabetes, hypothyroidism, Addison's disease. And important, it is also to think about other mental health conditions which can present like in eating issues. It could be depression, anxiety, mania, or psychosis or trauma related to the attachment issues. So there are multiple causes, but eating disorders is the most common one. And then, how do you get to know what is what? It is mostly, through your history, like you normally do, and your examinations and other investigations. Okay, when I say eating disorder, what do we mean? According to the ICD-10 criteria, we have anorexia nervosa, bulimia nervosa, binge eating disorder, and ARFID, which is avoidant restrictive food intake disorder. I don't need to teach you all. You guys know all these things. Just very briefly, I want to touch on the diagnostic criteria for anorexia nervosa. The main thing in anorexia is the weight loss, and the weight loss is so low that their BMI is 17.5 or less. And they are having this weight loss because they are not eating, they are restricting their food intake, or they are binging and purging. And it is mainly driven by the body image distortion that's leading to the significant weight loss. What is it different? The criteria is same. The anorexia criteria is same whether you are an adult or child or young person. But there are some parameters that needs to be adjusted when it is a child or a young person. So what we do is BMI is not a correct indicator, risk indicator. So that needs to be adjusted. What we do is we take percentage BMI. How do we do that? Is BMI by the median BMI for age and gender times 100. So this helps us to quantify the malnutrition, especially when the BMI percentile is less than second percentile. These days, there are easy things. We don't need to calculate all these things. There are apps that can do these things for us. So again, coming back to this young person in your clinic who is sitting in front of you, who is losing weight and not eating, you've taken all your history in your head. You did not find any indicators to think of other causes, and you are confident that it is more or less looking like an anorexic picture. So the next question, you would be thinking is, so what can I do with this patient now? And how do I know how severe this young person is, how ill this young person is? So the young person in front of you, you can get their height, weight, pulse, blood pressure. We would recommend sitting and standing blood pressure and temperature. So this will help us to guide us, do I need to worry about this person now? How ill they are? And we usually follow some guidelines. The guidelines we follow are Junior Marzipan guidelines. They're easily available. If you Google them, these are the guidelines produced by Royal College of Psychiatrists. And there is an app, Junior Marzipan app, we can all get on our phones. It's easy. I think we just need NHS Athens account or something. I've not tried recently. I have it on my phone. So it's easy to get. So in this app, you just need the date of birth and the day you took the measurements, height, weight. Then you can get the BMI percentile. The app will calculate the BMI percentile. And also the app has also got facility to tell you the risk indicators. These guidelines give you the risk framework. There is not one indicator, but thinking about, okay, what are the things I would be looking for, and probably when I need to act. This will help you as a guide. There are young people where where all those they could have normal bloods and things, but they can be still unwell. So it's important. It is just a guide, but it's there helpful for us for decision making. I'll just go through some of the things. The framework has got 4 criteria: blue, green, amber, and red. I'll be focusing mostly some of the amber and red. So that's where you would be thinking about you want to do something. You might have to act on that. And there are different criteria to think under this. For example, with regard to the food intake. If the food intake is less than 50, or if they have fully stopped taking the food, or if it is so less that it is less than 600 kilocalories per day, that's something for you to worry about. And if there is associated purging with laxatives or vomiting. And exercise, are they, with this current weight, are they exercising too much? If it is more than 1 hour per day, it's amber. If it is more than 2 hours, it's red. Other things you would be also looking for is the BMI percentile, I mean. So which you can get it from the app. It's easy, whether it is less than 80 or less than 70. And the important thing is not just the BMI percentile, it's also if there is sometimes the BMI percentile or could be normal, but there could be an acute rapid weight loss. That's important to know. Some young people present with very rapid weight loss. That's also important to note and ask in the history if the weight loss has been within the last few weeks. That's good to know. And also then checking about how their cardiovascular status is, how their pulse, is it too low? Is it less than 50 or less than 40 even? Are there any syncopes? The blood pressure. That's why it's important to check if there are any orthostatic changes. Is the blood pressure dropping too much? Is dropping by 15 or 20 systolic blood pressure, or diastolic by 10, or pulse rate increasing by 30. So that's an indicator of severity of malnutrition. The other important thing is it's important to check the blood pressure for young people. There are again centile charts for them. These centile charts uses their height percentile and age for both boys and girls. So their blood pressures are, as you all know, is different to the adults. So it's important to note that. And or they're hypothermic. Is the temperature is less than 36 or 35.5. The other small thing that you could do with the patient in front of you is what we call a sit-up, squat, stand test. It's an easy test. It's 2 parts for this test. The first part is patient lying on flat and then asking them to sit without the assistance of their hands, whether they can do that. And the second part is patient standing, whether they can squat and stand back without the assistance of their hands. If they're able to do it, then that's fine. It's scored as 3. If they are doing it but with noticeable difficulty, then we say it's 2. And if they are using hands to do it, then 1. And if they are unable to do it, it's 0. And then the other things that can help is, with regard to the ECG, is ECG normal? Is there abnormality in the ECG? And if that abnormality is due to any other biochemical abnormality. The other thing to note is severe malnutrition can also cause prolonged QTC, and are there any other arrhythmias? That test normally we would recommend, which is as per the guidelines, is FBC, hematinics, UNE creatinine, LFTs, thyroid function test, HbA1c, blood glucose, bone profile, creatinine kinase, magnesium chloride and bicarbonate, and vitamin D. I won't go through all of them. I will just pick some of them. So you guys all know that hypokalemia is dangerous. If it is less than 3, they need to be admitted. They need to be, monitored, and if it is so severe, then they need to be admitted. Hyponatremia is again, any of these, all these are mostly hyponatremia, hypokalemia, hypocalcemia, and hypophosphatemia. Hyponatremia is rare, but it can exaggerate hypokalemia. Hypophosphatemia can happen with malnutrition as well as refeeding syndrome, which we will touch in a little while. And hypocalcemia can exaggerate hypophosphatemia. And all of them can cause cardiac abnormalities, which can have unwanted impact. So with regard to the FBC, normally malnutrition can result in HB low, which could be normocytic normochromic anemia. In some cases, when it is severe, it can lead to leukopenia, white cell count are reduced and platelets reduced. These can increase the risk of infection. CRP is not usually related to anorexia, but it helps you to rule out any inflammatory bowel diseases. Urea electrolytes, you guys know dehydration can cause elevated urea, and it's important that if patients are taking laxatives, diuretics, or vomiting, that can affect the potassium, and if it is low, as we discussed, it can cause cardiac arrhythmia. Again, calcium phosphate, we already discussed this, and the refeeding can exaggerate already low phosphate levels. Creatinine kinase can be raised in severe cases, which means the muscle is breaking down. LFTs can be elevated in anorexia. In very severe cases, albumin can be low. That can lead to peripheral edema. This is important, refeeding syndrome. It's important to be aware. So a patient has come to you, say you said to the patient, you have an eating disorder. I think it is anorexia. Probably, after that, patients always, it does shock them, these young people and the families. It does shock them, and most people wants to get better, and part of it is they will start eating. So when what happens is the body has been starved for so long. When you start eating, the food needs to be metabolized, and it needs electrolytes for that. So the electrolytes shift from the blood into the cells, and especially phosphate. That leads to the hypophosphatemia. And if there is already a calcium deficiency, it can also cause hypocalcemia. But this hypophosphatemia especially can lead to cardiac arrhythmias and other neurological consequences as well. Refeeding syndrome is rare, but it can happen. So it's important to be aware. So then also thinking about, so is this young person in front of me in my clinic now, is this young person at risk of the refeeding syndrome? What can help me? What can guide me for that? So if their weight is too low, so like one of our red ones, BMI less than 70%, or if they have not eaten anything for a few days, or if their weight loss has been more than 15% in the last 3 months, and any other electrolyte abnormalities even before they started eating. So these can be an indicators for, who can be at high risk of the refeeding syndrome. Again, it's important, it's rare, but it can happen. But then because we know it can happen, if we are overcautious, then it can lead to underfeeding. So it's important to be aware. but that means it means close monitoring rather than underfeeding. So how do we, this girl would, after the clinic, would go back and would start eating. So what do I tell them about, their eating? So for the first thing is they shouldn't be taking any lower than what they have already been eating. I'm not expecting you guys, the full details, but this is the advice we generally give. For most young people, we would say, 20 kilocalories per kg per day or higher, usually 1000 kilocalories. Or, in our team, we usually go by portions. If the family goes by portion, okay, you're eating quarter portion, then increase to half portion, and then, that might be more safer. But if the bloods are abnormal, if the phosphate is too low, they need an admission. Again, this is reminding ourselves about the severity indicators like the ECG abnormalities, any signs of cardiac failure, electrolyte abnormalities. Again, the complication things is if there are any comorbidities, diabetes or infections, they probably need more close monitoring, and very, very low initial low weight. And for these people, usually the advice is start at a bit lower, like 5 to 10 kilocalories per kg per day. As mentioned before, it's rare, but it can happen. When it happens in the first few days of refeeding, but it can take up to 2 weeks after. That's why it's important to monitor the bloods. So they start eating at what they are eating and slowly increase by 200 kilocalories per day. And if the phosphate then drops, keeping the intake calories at the same level and not increasing until they are stabilized. And the blood test, usually the recommendation is daily during the risk period, which is usually in the first 2 to 5 days. And the monitoring for the blood test, even if the patient is in the community, they say it is no different to the inpatient, which is same as daily bloods based on the other risk factors if it's needed. Sometimes people need more, especially when they are in the hospital. And it's usually recommended to repeat after 7 or 10 days to see for any late refeeding syndrome. The aim is to achieve the full nutritional requirement for study weight gain in 5 to 7 days, but in reality, it goes really very slowly. Okay. For those patients who are orally refed without risk factors or being managed as outpatients, the frequency of bloods can be monitored, again depending on our assessment of how where is the risk, what are the risk factors for the refeeding. And if refeeding is being taken at home and the dietitian appointment is not immediately, usually the advice is about the portion sizes. Starting at the quarter portion, gradually increasing it to half portions, then full portions, then extra portions. So once over the initial refeeding period, usually after the first week, the meal plan should be altered so that they can continue to have weight gain of at least 0.5 to 1 kg a week. So coming back to how to manage anorexia in the primary care with this girl in front of you, the main thing is I have excluded all the other conditions. It's doing the risk assessment. We can use the framework junior marzipan guidelines, and with the things that in front of us like height, weight, blood pressure, temperature, and the blood test. And if the risk is high, refer to the pediatrics. If they need immediate attention, if they need to go into the hospital, they need to go into hospital. And at the same time, you can drop a referral to the camps as well, so the joint work can continue. If the refeeding, most people don't need to go into hospital, so they are in the community and with the eating disorder team. So they would still be monitoring of their blood test. So if the refeeding is in the community, they need their bloods to be checked. And this is the guidelines. The guidelines say until seen by the camps or the pediatric services, their physical health need to be checked weekly. Again, this is as per the guidelines. When a young person is in the camps, either a GP or the pediatrician may have to monitor the physical health. So how to refer to the camps? I think you guys all know it's through SPA. There's the phone number, there is an email, there is a address as well. You can write a letter or you can use the form they have. So if you just Google it, you can find it, or I have put it here. So who can refer you? The previous slide. This is for for the GPs, pediatricians, and social workers. But anybody else can refer. School can refer. Parents can refer, and people can themselves can refer. So we have a dedicated phone line. We call it as Here for You line. It's manned during Monday to Friday, weekdays 9:30 to 4:30 a.m. They talk to the person, they take the information from the person, they screen it, and if they deemed appropriate, the referral is made. The issue here would be because when the referral goes to the eating disorder team would request GP to see the young person as we discussed, because it has not been screened out for other things, and is it just the eating disorders that coming through our doors? What happens after the referral in camps? So they do the screening. The SPA will take the referral to the eating disorder services. Eating disorder services do their screening, and most of the times they do the screening of the paperwork, and then they follow it with the phone call and confirm that it is appropriate referral for them. And then they do an assessment giving with the formulation, and share the formulation with the young person and the family. And from there, the advice is mostly food is the medicine, and they help them learn more about their illness. Part of the package in the treatment program is their weight is monitored weekly. The team is well aware of the other behaviors that the young people can creatively do with their weights. They also get advice from the dietitian. It doesn't happen immediately, but it does happen, and the advice is mainly that they have regular meals and they eat with the family. And family takes an important role. Family are involved in the care throughout. And the idea behind this is to help family feel more confident and by parents being able to being empathetic as well as firm and consistent, because during the meal times the young people can present very distressed. So family able to cope with that, being empathetic, but again being firm and consistent as well, which is not easy. Important thing to remember, if you guys all know about Minnesota study, what all can the starvation do is a lot of things it can have. It can affect us in the cognition and emotional health as well. So it's important to know that antidepressants don't help for the anorexia. The depressive symptoms due to the malnutrition will respond to the weight gain. Olanzapine we don't regularly use in the community, because if the young person is severely malnourished already, so adding something without any close monitoring that can affect the QT interval is not always recommended, but it is taken case by case. But we do know when young people get admitted to the inpatient unit, they come out on olanzapine. When it was started, they were closely monitored during that period. It's only for a short period until they are able to eat regularly without the need for it. So with regard to the supplements in adults, there is a clear guidance about use of thiamine replacement and vitamin and mineral supplements. In young people, we do the practice is variable. Again, the evidence is limited. So whether to logically it makes sense, complete vitamin, multivitamin and mineral supplement is logical, and even thiamine prescription could be considered for the older adolescents. Magnesium and phosphate supplements, especially if their levels fall. So how does the EDS manage anorexia? The main therapy they provide is a family-based therapy, and the other therapies they can also provide is a CBT, cognitive-based therapy, specific to the eating disorders, and underlying main message is nutrition. I like this slide very much. It's important to remember the people involved in the young person's care. I couldn't put the young person in the middle, but if we imagine the young person in the middle, so they have their family, you guys in the primary care, and then there are specialist eating disorder services where we have a psychiatrist, dietitians, specialist psychologists, specialist nurses, and sometimes the young people's journeys are through different doors. They may be admitted to an acute hospital in a pediatric unit, or they might need admission in a specialist eating disorder unit. So it's important that all of us communicate effectively with each other. So why is it important? What is the prognosis of anorexia? So most people recover, about a half recover, but it's important to remember it's a chronic condition. Average duration could be about 6 years. Relapse is common. And this condition is worrying, anxious, because the mortality, this is the mental health condition with the highest mortality. 10 to 20% of the patients eventually die due to complications of the illness or suicide. But the positive on the brighter side is, if the treatment is at an younger age, it can lead to better outcomes. Very briefly touching on other eating disorders, bulimia nervosa, the main treatments we offer are CBT, IPT has got evidence. I'm not sure if we have that in our service. Here medication, there is evidence for fluoxetine, especially at the higher doses that can be effective. Important resources, there are few here with the guidelines, charities, growth charts, and the BP charts. I like this one. If you are interested, if you got a bit of time, Lou Thuru talking to anorexia is a nice, takes about 50 minutes or so.
So I've already said who I am, and I work with the adult services. What I hope to do today is to take a slightly different angle to Suneetha. Suneetha has kindly told us what the diagnostic criteria and what type of treatment intervention we do offer to people presenting with the 4 major categories of eating disorders. I'm hoping that this evening, what I'll try to do with my talk is to tell you a bit about what we do within our services, and more importantly, what clinical considerations you might be thinking when you have a patient in front of you. And lastly, it is going to be a whistle stop, and I hope it just doesn't stop there, that rather it starts a series of further conversations around how are we going to reduce the line of sight between primary care colleagues and secondary care colleagues around presentations of eating disorders. And on that particular slide, those are the kind of topics I want to breeze through. And I would like to start by asking, if you can go to menti.com, put in the code and use 1 word, 2 words, how do you feel about managing patients with eating disorders? What I'm going to do now is share my slide so that we can see what colleagues are putting in as, so bear with me. I'll give it a couple of seconds. Difficult consultations, frustrated, concerning, complex, risky, worrying, not very comfortable, inappropriate, better. 1 last second and I'll come out of it. Thank you. I'm going to come back to the slide, but I think I've lost my slide. It's really useful. Can you still see the slide? Because I can't.
Well, we can't see anything. I think you might need to share again.
Yes, I will need to reshare it. But I think it's useful because actually we in secondary care services, we do go through the same raft of emotions when we have patients referred to us with eating disorders, especially if they are the ones with severe to quite complex ones. And what we do is just work it out from go back to basics. And coming back to adult eating disorders, we're a county-wide service, though we're quite a small team. And we admit our patients to Leicester, which is where our admitting unit is. We don't have anything in county. And for our community provision, it's through 2 pathways. So some come to us, some go through steps to change. And I'll come 2-3 slides down the line to talk about those that go through the 2 different pathways. One point I really want to pick on, and which I hope will start those conversations, is the long-term plan. There are a lot of changes going on, and I think I'm somewhat vested in today's conversation in that I wear 2 other different caps. I am clinical director for specialist services and work alongside Eve, as well as having an East Midlands regional clinical lead role, looking at how to transform eating disorders across East Midlands in line with the long-term plan, and having regular conversations with GP colleagues down the road in Peterborough. So I'm hoping that with today's conversations, we can carry that forward after today and look at how we can improve services for people that come through our doors. Who do we have in our team? We have our team coordinator, psychiatrist, myself, I'm not full-time. We have a full-time psychologist, 2 full-time clinical nurse specialists who delivered interventions around CBT, or mantra, or any of the other NICE recommended treatment interventions. You can see there that our dietetic input is not too great. We do offer day program, which most service users actually prefer because it prevents admission to hospital. It retains their community links. It maintains their social network. So actually, it's preferably, it's cheaper, but it's difficult to get any of the budget holders to set this up. So that's one of those things you think is a quick win and a cost-effective way of providing services. And what we offer, I would really like to promote the guidance and advice line. I don't think it's used enough. We get the odd letter or email from primary care colleagues asking for advice, but I think it's something really I encourage colleagues to use. Email us if you're worried about a patient, you're not quite sure, you should refer to us or to steps to change, or if you're not sure it's eating disorder at all, ring us up, email us, and we're happy to have a chat. We offer psychological intervention, all in line with NICE guidelines. We do have limited physical health monitoring, which is provided by myself and some of the clinical nurse specialists, and is one of those pathways we're quite keen to develop, especially in line with the national press around eating disorders, and sadly the losses we have had in those domains, purely because we haven't got our ducks lined up well. We do provide consultation and liaison to other mental health teams like CMHT. They might have people who may or may not have eating disorders, but don't quite want to work on that. They don't want to do any therapy with our team, just want to live with the condition and maintain quality of life. So we support those teams to do that alongside our day program, and the community support there again is some sort of an enhanced provision where people, if they don't go into hospital, if they are too unwell to access therapy, people can go out and meet them either at home, coffee shop, or wherever. Even in colleges, we've met people in college, we support them to go shopping, depending on where their difficulty lies, in order to move things forward for them. Referral criteria. I'm not really a great fan of criteria, because by intention, you're going to exclude some people. And we know what the 4 or 5 eating disorders are. So what I've tried to do with that slide is just to represent that for us on the left side, which is the team I sit in, that there is our number, email address, and the SPA, which is a single point of access. Unfortunately, if you decide to refer, they still have a referral form, which you will need to complete. But if it's just advice and guidance, send us an email or ring up and the message will come through. We usually pick up the complex and the moderate and the severe ones. So those with rapid weight loss, anorexia with less than 17.5, complex bulimia, or those with associated risks. So example, maybe somebody with bulimia who is pregnant or who has a comorbid diagnosis of diabetes. The rest of the eating disorders will have to access their therapy intervention via Steps to Change. And again, they can either self-refer to Steps to Change, or primary care colleagues can refer them there. Unfortunately, at this moment in time, for the adult eating disorder service, we don't accept self-referral. But again, that's one of the long-term plan ambition, to do away with referrals and allow patients to self-refer to services. So I guess that's one to watch out as things progress. And context, really, just to set, if you go back again to that mental slides where we talk about when we see people with eating disorders, why do they elicit such emotions in us? So again, remind ourselves that eating disorders, it just stretches across almost all domains of their lives: physical, psychological, social. And then that have quite a huge impact on their health risks. As Suneetha pointed out, like anorexia, it has quite the highest mortality in psychiatry. But again, I think we then underplay the associated health risk that bulimia and binge eating presents with. So that's one not to lose sight of. And patients, actually, 2/3 of the patients are not managed by the specialists. They sit somewhere in the system, whether they sit in primary care, out of sight, or they sit with the CMHT. And one of the long-term plans and ambition is to support each other, to identify those patients and identify what type of support they need to live with their condition. And I guess in some way, giving people that chance or that opportunity to live the way they want. And following up from that, it then means that duty of care will not fall within the specialist team. It will fall at some point to colleagues in the primary care, at some point to general psychiatrists, or even to social care, social prescribers who may provide some social care support to them. Again, I'm not going to waste time on this. Suneetha has nicely picked it up, the DSM-5 categories of eating disorders we have. Just to point out, at the moment, we are commissioned to look at the first 4, which is the anorexia, bulimia, binge eating, and OSFED. And I think though in children, they do take ARFID, some services, and nationally there is a lot of conversations that those children seen as a child, as a young person with ARFID, they will need to be followed up as an adult, understandably. So there is that discussion and push for for a service to be nationally commissioned and recognized for people with AFID. Not quite there, but probably not far off. And what I intend to do with the next 2 or 3 slides is to start to point out where your high index of suspicion should be. Should you see a patient in your surgery and you're thinking, I'm not quite sure, is this anxiety, is this depression, what is this about? So we don't know what causes eating disorders, but what we do know is that if you're likely to have an ED, if you're a female, if you're an adolescent, especially in your late adolescent years, if you're in a period of transition, and I think particularly this is where we sometimes miss the boat, particularly specialist services, because you have university students who go, for some reason, when they go to university, they choose the town very farthest from where their parents live, where they want to be far as from parents as they can possibly be, which means they pitch up in Lincoln, parents are in Manchester or down in London, and they are now obscattered, they can't manage. The only thing they can control is their eating habits, and they hit your surgery. Probably you might be thinking they are missing home, these are anxiety, they do need to go out more often. So again, if you have that anchor in your mind, transition, that might be something to look out for. If you're moving houses, or even if you're transitioning jobs, again, that might be a point in life you might develop with an eating disorder. Then again, around diabetes, where you have your bulimia, and you have those who are preoccupied with their body image, who wants to be slim, and they're always excessively onto one type of diet or the other. So those are the kind of things to keep your eyes out for. And the second part of that slide, if you've been sexually abused in your formative years, if you are a worrier, if you're anxious, worrying all the time, do you have enough friends? Does my friends like me? Am I good enough? Am I pretty enough? And the funny thing is that when you see those that do eventually present with eating disorders, they are quite forthcoming with these symptoms that on their own, it doesn't quite add up. But when you begin to piece them together, a picture starts to form in your mind. So those with very perfectionistic traits, they just want to get it right, hit the right levels of A+ in their in their A levels. They want to they struggle to make a decision because they're not quite sure if it's going to be the perfect decision. So those are the kind of people that if anything goes wrong, it's catastrophic, anything trivial. So again, it begins to give you that picture of somebody that needs a control, and the only thing they can keep a consistent control over is what goes into their mouth. The last one, or the last 2 slides, there, family history of eating disorder increases your chances of having one. And those that will subsequently develop bulimia or binge eating will be those that will be always over obsessed with their body weight. They eat a diet this week, they lose control of the diet, they eat more, they then go back on the diet. So they're always worrying. And usually they come to you asking, can you refer them to dietitian? Can you refer them to the gym? Do they need this? So again, there are some level of presentation that probably will begin to make you think that there's something more to just a common mental health presentation. This is just a summary. I'm not going to spend a lot of time. It's just, I like the slide. It gives you that quick overview of if I'm thinking this is binge eating, what do I need to do? So look at the symptoms there. With binge eating, there's no compensations. You're looking at the one on your right, or my right, should be on your right as well. They binge, they feel guilty, and somebody with other positive coping strategies might do something else to manage the guilt, but somebody with binge eating would then binge again, and then that starts a cycle. Same with the rest of the column. And the risks we're always worried about from eating disorder, which drives this new model of care I'm going to come on to, is that if you get them early, their prognosis is better. But if we leave them a day longer, a week longer, the risks we are looking at goes without saying. If you have significant restriction is going to leave your brain starved, you have confusion, all sorts of presentations, the heart hormone disruption. What I want to point out with this slide is the hormone disruption. Time and time again, and I'm sure if we take anecdotal stories, you have young ladies brought in by their parents, they haven't seen their periods. Those are always their concern, but you then wonder, you then have to make the connection. Maybe they've just finished A-levels or they're off to university. And again, go back to those 2 blocks of slides I have there. If you remember them, you can then unpick some of the symptoms that may come, or you might want to pick out when they come with their history of hormone disruption, or when they come with a history of, I think I might have a food allergy, I might have a celiac, can I get a test? Take a food history. It might uncover much more than just a food allergy. And the easily missed groups there are your men. If you go to an eating this, even in our service, is full of women. Most times, one or two men in 1 year. So if our full referral for 1 year is gone up in the last year, but usually we average about 200 in 1 year, and mostly they are females. We might have 10 odd male referrals. So they are not very common. And when they do present, they present with high risk because understandably, they are not picked up early enough. And they then come when the physical health compromises are well established. Associated with men is bigorexia. So you have young teenage adolescent boys who decides that actually I want to build up my muscle. So it starts with very innocent looking, going to the gym very often with my friends, needing to take protein shakes to build up and keep up with the personal trainer. When you come across them, you need to unpick at what point did it become so obsessive that if they miss out a gym class, it is the end of the world. If they run out of their protein shakes or their steroid shakes, what effect does it have? Does it cause a lot of disruption that doesn't equate to just running out of a protein shake you have at home? Anorexia, those are very healthy eating. So suddenly somebody that would have just easily gone into McDonald's to get a Big Mac, or would have easily ordered a takeaway, they start looking at health, the food ratings on foods. They start looking at very healthy eating, and obviously very, very healthy eating comes with a very narrow range of foods you can eat. Bulimia, those with diabetes that use their insulin to control their weight. This last group is quite high risk, and most times there's not much you can do apart from keep a close eye on them, detain them when they are very highly compromised, continue with intensive CBT, and keep your fingers crossed, because the risk is that most of the time they are just on the cusp of okay. Is once every so often they have to take more than the insulin they needed, and they go into DKA, and they end up either in hospital or end up in working centers. I just wanted to touch on disordered eating and EUPD because it's something that we've seen grow exponentially, partly because of what is going on around the world, or partly just because that is the time it's rearing up its head. It's usually associated with people with borderline personality disorder, where they just control their amount. It's not as long-lasting as diagnosable eating disorders, but that doesn't mean that the physical health compromise is not the same. Below there is the conditions that the criteria that meet that diagnosis. I want us to just spend another few minutes, if we can, on answering the second question. I think it's the same code we used for the last one. And what I'm asking is, you have Molly, who is a 19-year-old, year one at the university, come to see you, worried about her studies, not eating well because she's busy, taking up going to the gym as a way of managing her anxiety. What are you going to do? So if I pull up my slide again, and I hope it goes smoother this time round. Are you able to use your code? I'll give it a few seconds. So see her again to get to the bottom of the issue. Give her a self-referral to steps to change. One more second, I'll come out of it. So yeah, I'm pleased. None of us is about to start her on an antidepressant, or we're not going to reassure her that she's okay or capable, because we know that she's really struggling. And I'm going to come back again. And really, yeah, I think with that particular question there is probably more than one options one can choose from, which is see her again to get a clearer picture of what's going on there. And if I had to, I think I put in there self-refer to steps to change. And that in itself is something to highlight, because if you remember in our medical student teaching that people with eating disorders would deny it. So if you leave them to refer themselves to steps to change, they're not going to do it. So it's easier if you do the referral. It might be a bit of an extra work at that point, but actually you're helping to get that patient the help they need quicker rather than leave it later. You can see that I'm not quite good at going from Menti to my slides, but we'll get there eventually. So we decide to refer. You've seen how handful of times you're quite certain that this is more of an eating disorder, that she's better off seeing earlier than later. And what I've tried to do with that initial slide is really those questioning ideas that will help you spot an eating disorders. We used to know about the SCORF, the 5 questionnaire you ask about: do they control their food? Do they make themselves sick? Do they have a fear of fat? And I'm aware in general practice you do a lot of ideas, concerns and expectations, but actually quite recently, one of a GP in training has developed the ABCD I put there. Her website is towards the end, and she has a lived experience of eating disorder. So she felt that actually, instead of using I's, using ABCD, so absenting, do they take themselves out of the social network when it's food time? So when there's time for family to sit down as a family and eat, they tend to find an excuse not to be there. When friends are going out, they have an excuse not to meet up. Are they preoccupied with their... So similar ways of SCORF, but I guess it gives you more ways of asking better detailed questions. Don't forget your triangle of care, where you can actually speak to parents, speak to carers, speak to friends at the university if they allow you. It allows you to get a better overview. And I know you do have 10 or 15 minutes, but again, if you go back to one of those options, see her more time, more than one, so you can see her 2 or 3 times to get a better picture. And more importantly, I know in the olden days, we used to say, let's wait and see if he resolves. With eating disorder, if you suspect it is an eating disorder, make an early referral, because we know that if you identify them early, start them on treatment, the prognosis is better. And you do have the Freed model, which is ongoing and is being rolled out nationally, an early intervention in eating disorders. Initial assessment, your food history, as well as the other standard assessment. And food history is really quite important. It gives us an idea of what the relationship with food is. I'm not going to go through the other ones for time, and also that has been covered in Suneetha's presentation. And the slide there looks quite busy, but it gives you a good summary of what the risks are and where your patients will sit. So if they're moderate risk, you're safe referring them on to be seen and monitoring them as they wait to be seen by the specialist. If they fall in the high risk, consider a same-day admission to a medical ward. That means their physical health is quite compromised and they should be having a regular monitoring on a medical ward. I'll just allow that to come over. So ongoing care, they are now being seen by eating disorder team. What then happens? We don't own them, we don't take them away, and we hope that it's going to be that slide there quite nicely captured that it is a joint effort, it's a two-way relationship to manage that patient, and they will need their medical monitoring. And I guess for me, medical monitoring is a long-term and a short-term thing. In the short term, it may well be a case of trying to stabilize the patient, see them more often. And whether they're taking our primary care or secondary care, that is a debate ongoing. But I think what we shouldn't lose sight of is that a patient needs to be seen. And increasingly, patients prefer being seen within their locality. So there is an argument there that a joined up, shared care, whatever umbrella we want to put it in, working out a modality of managing the medical risk while they access any intervention they will need to would be good. Again, I'm not going to spend time on refeed syndrome. It's been covered by Suneetha. What I would like to take out from the next two slides about refeed is that back in medical school, when you hear about refeed, you think straight off it has to be on a medical ward. Actually, 2/3 of the patients we manage within my team, we do their refeed within the community. So far as you start gradually, and again, it's going to be initiated by the specialist team and jointly managed between specialists and yourselves. So you might see us at times writing to you saying, can you do their bloods maybe weekly because they are nearer to you than coming into Lincoln to have their bloods taken at Lincoln County. You might see us asking you to prescribe the high impact multivitamins or even prescribe some supplements. And what I'm hoping again that further conversations will open up is how do we navigate that difficulty in communication and make it easy and make it a better outcome for patients we both manage. I think this is the last of my slides on mentees. So if colleagues don't mind, let's give it a go. And this is actually a real patient that still is within our team currently, recently taken on by us. So Beth, 34, chronic anorexia, BMI 14, came to you because of a further weight loss due to COVID. Her new BMI is now 12. I think it's a different mentee. I'll come to a different code. She doesn't want to come back to us for treatment because she's had 2 or 3 treatments in the past. She functions reasonably. She's a teaching assistant, I think, or actually she's a teacher now. She's finished and seems to have capacity. What are you going to do? So I'll give it a second or couple of, okay. We refer her to AEDS. Remember, she seems to have capacity. She doesn't want to be referred back to us. Do nothing, it's her choice. Any more for any more? Refer her to the community dietitian. Thank you very much. And actually, what the GP did was refer her to the community dietitian, who saw her, managed her, and I'll come back to the same slide. The GP referred her to the community dietitian. They saw her for some periods of that was from November last year till April this year. And she went back to the GP because she needed some physical health check for PIP. And the GP at that point noticed that her BMI has gone down to 10.9. And the GP, what did you think the GP did? Call your friendly EDS. Please, somebody chose that one. Urgent referral to AEDS. And you'll be pleased to know this is the last of my attempt at Mentimeter. Remember that her BMI is 10.9 now. Actually, I missed out that her neutrophil was not 0.9 at the point GP saw her. And what did the GP do? We didn't select that. The GP did a same-day admission to a medical ward because her BMI was 10.9. Her neutrophil was not 0.9. And I guess if you're thinking of doing a same-day urgent referral to us, there's not much we can do. We'll still have to send her straight away to medical ward. And I suppose in some sense, if you go back to that slide that has your physical health risk, which we call the predicts, it has it in a moderate and high risk. If you have it to hand and looked at it, Sally, or whatever that lady's name is, would have fallen into the high risk and referring her. And we're getting better in Lincoln County. Usually we use Lincoln County to stabilize them, and they are quite good at accepting them and getting in touch, which is what they did with that patient. Admitted the patient along with the GP's instructions, and once the patient was stabilized, they let us know, and we then started seeing the patient. I think that would be the end of, I'm trying to go back to my slide just to make sure that I have finished, but just a handful of conversations there towards the end I would like to point us to before I finish my talk. For some reason, it takes me back to slide 1. So I'm going to go forward. So that's that lady, you see her again, Menti. So moving forward, if you remember when we started, I said that I have 2 other caps I wear within eating disorder: clinical director for the service, as well as the clinical lead for the transformation plans for eating disorders. And I think we're at an interesting time when eating disorder is taking a central stage and we're wanting to get things forward better. So I'm hoping that in one of the conversations we're going to have, we'll consider things like GP champions, having enthusiastic colleagues who would like to know more about eating disorder, know how to manage them. There are regular trainings associated with that, regular meetings. And I know there are lots of ROs and mental health practitioners coming on within as part of the transformation plan. Are there ways you can use them to deliver the long-term plan? I'll leave that there. Regular conversations, Mazepam training, which we are starting for the acute trust twice a year, 2 hours, 2 times a year. So please feel free to attend them if you feel it to be of help. And more importantly, Emma Tiffin, who is a GP down the road from those in Stanford or Bonn, she has a huge interest in eating disorder and doing wonderful things there. Is that something we can replicate across here? And Elizabeth McNaught, she is the GP in training with a lived experience that's come up with the ABC. So those are colleagues like yourself. So for me, seeing them, it tells me, it gives me that confidence is doable. We can do this, is having that shared interest, that shared enthusiasm. I'll put up some resources there and cheekily or mischievously put into there, which is to do with service development, the PCN and mental health, and the one around commissioning around eating disorder services. If you have time, skim through it. And I guess I'm saying this because NHS England, the government, the patient, they want to see things done differently. And I think if we all get ahead of that curve and have conversations and put things the way we think services should be, obviously we co-produce with patients, I think that would be a good way to start. And I would like to call on colleagues to look at taking that forward. The next two ones are just resources there you can tap into. So websites for trainings around men with eating disorders. Yeah, and that is the end of my presentation. Thank you very much.
Thank you. Thank you, Dr. Siddabattuni, for your presentation. It was really nice. Thank you, Dr. Bradshaw. It was a wonderful presentation. I think from the Mentimeter survey, you would have seen that it's a very uncomfortable field for us. But you have cleared a lot of queries and it was really useful. Thank you for that. Shall we go into the questions now? Are you ready for the questions? I can't hear you. You're on mute. Both of you. Sorry.
Yeah. Carry on.
Yes.
Yeah.
Okay. There are a few questions. The first question is, the red and amber criteria, is this strictly for patients with BMI less than 17.5? Hello?
Hello. Yeah, usually the red amber is developed or extracted from the Mazepam guideline, which more or less is around anorexia. However, your patients with bulimia will present with the same low potassium. At times, they'll present with deranged liver function test. So in as much as I use it for all the 4 categories, I don't just restrict it to anorexia, and I then reference a rationale for making that decision.
Thank you. Next question is, does anorexia cause a derangement of ferritin and B12?
Usually, I don't know what Suneetha thinks, usually not often, unless it's towards the quite late stage. So when you have somebody who is very chronic, BMI below 12, most of their biochemistry will be deranged. But if you have people with bulimia who are cycling out of compensatory behaviors, or people with anorexia, BMI higher than 15, ferritin B12, not really usual. If I have them as deranged, I'll ask the GP to exclude other reasons for it. That would be the usual practice.
Thank you. The next question is, they're asking about the average waiting time for the patient to be seen by the eating disorder clinic when we refer for a patient.
The average time to be seen. Before COVID, we didn't have a waiting time, but COVID happened and we developed it, and then we lost a staff member. And that same is replicated in steps to change as well. So currently, for adult eating disorder, it's going to be around 6 to 8 weeks. Okay. It's even longer if it steps to change. However, and Suneetha will correct me, for CAMS, it's for children and adolescents. They have a waiting times, and I don't think they've breached it. They might breach it by about a day or two, but for children, it's usually 7 days for urgent and within 28 days, within 14 days for a routine, and they more or less stick to that arrangement.
Yeah, just to add, I think pre-COVID it was going okay. I think post-COVID there has been increased referrals. I don't know the exact data, but I hear from the eating disorder colleagues they are finding it difficult to keep up to the timelines. It's usually, as Adaeze said, urgent referrals are seen within 5 days, less than a week, but they are struggling to get there. The routine referrals used to be within 4 weeks. I don't know the exact numbers, but they are really, really stretched at the moment.
Thank you. The next question is regarding the leading admissions. I think you have covered already in your topic. You're asking whether the patient has to be admitted in general P or medical ward or should be referred to the psychiatry. And the follow-on question to that is, should the patient is in high risk, should it be admitted to medical ward or medium risk urgent AED referral, and low risk would it be in routine AED referral?
Sylvia, I didn't hear most of it, so I'm going to pick up the bits I heard. If it's high risk, a patient is physically compromised, admission to a medical ward, usually they go through MEAU, they receive them at MEAU and they stabilize them. And they do have a marzipan protocol they worked with and they admit them. If it's medium to moderate, refer to adult eating disorders, or if it's mild to moderate, steps to change. But obviously, the good thing about CAMS is that if it's mild, moderate, or severe, refer to CAMS EDS unless it's high risk, in which case you need to seek an admission to pediatric ward for a young child.
Thank you, Adaeze. The next question is, I think they're asking at contact details for ED services, which you have already posted in your presentation, and it will be circulated among everyone so that they can see that. And the next question is regarding the referrals, and they're asking GPs to do the blood test. It says that practices are often inappropriately asked to carry out physical monitoring of patients with ED. This is outside the scope of general practice and not funded. These patients have high mortality risk, and practices have been instructed by the LMC to decline to monitor physical health. You have an update of when a service will be commissioned to do a specialist monitoring.
I don't have an exact date, but I guess what I would like to throw into the mix is that I would like some volunteers of GPs to start that conversation of how we want it to happen. There is a mandate from the Department of Health, NHS England, that it should be in place. And I'm sure you would have seen the coroner's inquest from Peterborough, and there is a discussion, but I guess, and I agree with the colleague that said it's a high risk area and GPs don't have the specialist skills, but you do manage people with other chronic conditions like, say, oncology or people with kidney failure. I guess it's again looking at how can we develop a pathway that mild to moderate can be jointly managed at the primary care with an oversight from the secondary care. And that's the discussion we're having. But what I would like to see happen more is to have volunteers from younger generations of GPs like yourselves so that we can actually have a sit-down conversation and look at what models or protocols they use elsewhere. I'm aware in Norfolk, there is a model there. In Peterborough, there is a model. So we can actually look at it and say, this is what we want to happen here. This is what we think will work for us. How can we implement it? I think there is opportunity. We just need to get our houses together. And if people want to send me an email or send Suneetha or Eve, who is in the conversation, I'm happy to have emails, and then we can arrange to start that conversation going.
Thank you, Adaeze. Next question is, regarding interpreting the children's ECG with eating disorder, because GP is not always skilled in interpreting a child's ECG. The question is, who will do that if we wanted to have an ECG done for a child with eating disorder?
Yeah, completely agree. GEP is not skilled, and equally CAMS clinicians as well. So we usually ask for pediatrician who is an expert in cardiology. So if we have a pediatric cardiologist or somebody who has interest in that, so we will ask their opinion. Normal ECG I wouldn't, but if I have some concerns about the ECG, I would ask their opinion.
Thank you, Suneetha. The next question is, someone has said that they have a patient with normal BMI, but on the edge to go down. Can I refer or step in?
They have normal BMI.
Yeah.
And what was the second bit?
But on the edge to go down. They're just declining slightly.
Mm.
What mode of referral would that be? Would that be to the eating disorder service or the step?
You see, with that is the one I would like to have more information around their food history, because it can still have normal BMI, but it hasn't told me if their symptomatology is anorexia or bulimia. Because even we see some normal BMI at anorexia within our service, if they are complex or if they are rapidly losing weight. So I guess if I have that referral, what I'll be asking the colleague to do is to give me more food history to make me decide where they can go to.
Yeah, okay. Thank you. And the next question is how to manage a 15-year-old who refuses to be weighed or have blood tests done.
Interesting. I had a young person who was really unwell, and she had fear of needles and didn't wanted to have bloods. We do come across that and lots of negotiations happened with the young person because she refused a lot. But her pulse was so low, we have to say, look, we really need you to have, because, you know, we are worried about you. I think we need to, you know, use the information we have to express the concerns. What usually works with young people is they can say, okay, we need to know, especially if it is the beginning, you know, you need to know whether, you know, they're too unwell, whether there is other history that can tell you. With regard to the weight, they can say, you can ask, you know, if you don't want to know, that's okay, but I need to see. And once I say, if you want to know, I can tell you what it is. If you don't want to know, that's okay. But it can help me, guide me to know what it is. That helps. You know, they do usually accept initially, but, you know, down the line, they would say, okay, this week I don't want, okay, I don't want to know. But you would know from the history, okay, I'm exercising more, I'm eating less, I stopped eating. You would know other things. So it's not just one criteria, it's, you know, other criteria as well.
Okay, thank you. The final question is the question about sectioning, whether you would section someone with mental capacity who has eating disorder, or do you never do this as they have a capacity?
So say that again. So do you section somebody with mental capacity?
And they have an eating disorder. Would you or would you not section someone who has an eating disorder and when they have a capacity?
If their life is at risk. So if you remember with your mental health, you need to meet 2 criteria, 3, risk to your health, risk to your safety, and risk to others. If their life is at risk, so if you have somebody who is self-starving, haven't eaten for 5-6 days, you can see cognitively their blood profiles are deteriorating. Yes, you can section them. And usually if they are quite physically compromised, we section them to a medical ward till they are stabilized enough, and we transfer them to a specialist eating disorder unit. Or if their physical health is moderately okay, you can section them directly to an eating disorder unit.
Thank you. Thank you for the answers. I think that's the question.
Thank you
Thanks
very
a lot
much.
for all the answers.
Thank you, Selvi.
Okay. Thank you.
And thanks to our speakers, Suneetha and Adaeze, for your time this evening. And Thanks everyone who attended.